Good morning, students.
Good morning, sir.
Good morning.
Why only 20 students?
They will join now, sir. They will join.
So I will wait you for 5 minutes. My presentation is visible.
Yes, sir.
Today we will talk about acute pancreatitis. Acute pancreatitis is characterized by inflammation of the exocrine pancreas and associated with acinar cell injury, and both a local and systemic inflammatory response. AP may range in severity from cell-limiting, characterized by mild pancreatic edema, to severe systemic inflammation with pancreatic necrosis, organ failure, and death. Here we discuss current diagnostic and management challenges and address the common dilemmas in AP. AP has a mortality rate of 1% to 7%, which increases to around 20% in patients with pancreatic necrosis. The mortality rate is influenced by the severity of the disease, with several prognostic factors having been described. The presence of persistent organ failure is associated with the highest mortality, which is as high as 60% in some series. Gallstone pancreatitis is more common in women over the age of 16, especially among those with pancreatitis, while alcoholic pancreatitis is more frequent in males. Etiology. For ductal obstruction, we have etiology of gallstones, alcohol, post-endoscopic retrograde cholangiopancreatography, malignancy, mucinous tumors, pancreas division, sphincter of Oddi dysfunction. For acinar cell injury, we have alcohol, trauma, ischemia, drugs, for example, corticosteroids, azathioprine, and thiazides, and viruses. For defective intracellular transport, we have alcohol, cardiopathy, hypercalcemia, hypertriglyceridemia, and autoimmune. Several etiological factors have been described for AP, although in up to 30% of cases, an etiological factor cannot be identified, termed idiopathic pancreatitis. The presence of microlithiasis accounts for 80% of idiopathic pancreatitis. In the UK, gallstones, followed by alcohol intake, are responsible for 75% of cases of AP. The most common cause worldwide is alcohol consumption. Pathophysiology. The initiating event in AP is due to acinar cell injury and impaired secretion of zymogen granules, and involves extracellular, neural, and vascular mechanisms, as well as intracellular mechanisms, such as intracellular enzyme activation, calcium accumulation, and heat shock protein activation. Increased calcium transients potentiate colocalization of zymogens lysosome granules, and ultimately premature conversion of trypsinogen to trypsin. Medications that may cause AP through acinar cell injury include azathioprine, corticosteroids, and thiazide diuretics. Ethanol-induced pancreatitis has different pathophysiological mechanism. Ethanol is directly toxic to the acinar cell, leading to inflammation and membrane destruction. There is also evidence that ethanol increases pancreatic ductal pressure, favoring retrograde flow and interpancreatic enzymatic activation. It is likely that the ischemic perfusion injury plays a role in the development of AP, which is supported by importance of early aggressive fluid resuscitation. Microvascular changes may lead to increased pancreatic vascular permeability, edema, hemorrhage, and pancreatic necrosis. These hypotheses have led to detection of novel molecular therapeutic targets such as tumor necrosis factor alpha and interleukins, both important activators of the inflammatory response in AP. Diagnostic approach. The diagnosis of AP must be considered in any patient presented with abdominal pain. History and examination can be indicative of AP. However, 2 out of the following 3 criteria should be met for diagnosis. Typical history, elevated serum amylase oligase, more than 3 ULM, and imaging CT, MRI, or ultrasound consistent with acute pancreatitis. A full history is required determining the nature of the presented abdominal pain and for the presence of risk factors for pancreatic disease. Age and sex are important demographics because the 2 most common causes of AP differ. Gallstone pancreatitis is seen most commonly in patients with gallbladder disease, typically women over the age of 60, while alcoholic pancreatitis is seen more frequently in men, and generally at a younger age than those with gallstone pancreatitis. Metabolic, drug-related, and procedural etiologies should be considered. A history of previous AP should be documented. A family history is important to exclude hereditary pancreatitis and familial cancer syndromes. All medication, and in particular new medicine, should be reviewed. The most common presenting pattern of pain is severe epigastric pain that radiates to the back, is exacerbated by movement and is elevated by leaning forwards. Patients may appear agitated, confused, and in distress. That may give a history of anorexia, nausea, vomiting, and reduced oral intake. A history of symptoms in keeping with associated with phalangitis should be sought. Physical examination. Patients usually have signs of hypovolemia and may appear diaphoretic, tachycardic, and tachypneic. Fever may occur due to easy cytokine release as part of the normal inflammatory response, or may represent complicated pancreatitis, for example, pancreatic necrosis with or without infection. Reduced breath sounds and stony, dull chest effusion suggest a pleural effusion, which may rarely be present on initial presentation. Also commonly develop as a later complication. The abdominal examination may reveal a tender and distended abdomen with voluntary guarding and with reduced bowel sounds if there is an associated ileus. Clinical signs of hypocalcemia are rare but may be evident. Laboratory investigations. A meta-analysis found that an elevated serum ALT concentration of 150 IU per L or more within 48 hours of symptom onset had a positive predictive value of 85% is in predicting a gallstone etiology in patients with AP. Elevated levels of serum amylase or lipase more than 3 ULN support, but not pathognomic for diagnosis of AP. Early and serial C-reactive protein testing is used in AP as an indicator of severity and progression of inflammation. Arterial oxygenation should be closely monitored and depoxy treated with supplemental oxygen. Arterial blood gas sampling should be considered in order to assess with oxygenation and acid-base status. Amazing. Transabdominal ultrasound is a preferred initial study in suspected gallstone pancreatitis, as it is inexpensive, available, and bedside, and allows examination of the gallbladder and biliary tree. Patients that become systemically unwell, septic, or who do not improve should have a multi-phase contrast increased CT scan to rule out peripancreatic collections, necrosis, abscesses, and vascular complications of pancreatitis. For example, development of portal venous thrombose, pseudoaneurysm, or hemorrhage. For serial examinations, MRI is gaining favor with the use of MR cholangiopancreatography and RCP sequences to detect exclude etiological factors, including biliary and pancreatic stones. Improved depiction of the solid and liquid components of pancreatic and peripancreatic collections, thereby facilitating planning of drainage procedures and better characterization of pancreatic parenchyma, including acute inflammation, residual worrying, and fibrotic change from previous insults. Endoscopic retrograde cholangiopancreatography, ERCP, is only recommended acutely in cases of gallstone pancreatitis complicated with cholangitis. A meta-analysis found no evidence that early routine ERCP significantly affects mortality or morbidity in biliary pancreatitis other than in those patients with coexisting cholangitis or biliary obstruction. Treatment. The main goal of initial treatment is to alleviate symptoms and prevent complications by reducing pancreatic secretory stimuli and correction of fluid and electrolyte abnormalities. Initially, patients should be fluid resuscitated and kept new by mouth with bowel rest when nausea, vomiting, or abnormal pain are present. Supportive care continues until pain is resolved and diet restarted. The majority of patients will improve within 3-7 days of conservative management. Patients with organ failure or poor prognostic signs, persistent SIRS, Glasgow score more than 3, Apache score more than 8, and Ransom score more than 3, should be assessed for admission to high dependency unit. Initial resuscitation. Resuscitation with intravenous fluids, analgesics, and antiemetics should be formed part of initial treatment, even before the diagnosis of AP is made. Goal-directed rehydratation with Ringer's lactate solution or Gartmann's is recommended at a rate of 5-10 ml per kilogram per hour until resuscitation goals are reached A recent triple-blind RCT compared Ringer's lactate to normal saline in AP and found that Ringer's lactate was associated with an anti-inflammatory effect, which was attributed to the properties of lactate. A urinary catheter should be inserted in severe AP in order to record accurate fluid balance. Overly aggressive utilization leads to increased rates of sepsis, the need for more mechanical ventilation, and higher mortality. Therefore, infusion rates should be carefully tailored to individual patients, taking into account factors such as age and comorbidities. Adequate early fluid resuscitation is the single most important aspect of the medical management, reducing organ failure and hospital mortality. Effective pain control is important in order to prevent diaphragmatic splinting, thereby reducing the risk of respiratory complications. The most commonly used drugs are opiates, morphine or fentanyl, either for breakthrough pain or as patient control analgesia. Close monitoring of arterial oxygenation, acid-base balance, and blood glucose should follow the intensive treatment modes of other critically ill patients. Severe pancreatitis and antibiotics in AP. The treatment of severe pancreatitis should be delivered in a high dependency unit. Insulin should be administered to maintain strict glucose control, as this has been associated with reductions in morbidity and mortality in critical illness. Hypocalcemia and hypomagnesemia should be identified and treated to avoid the development of cardiac arrhythmias. The use of antibiotics in non-infected pancreatitis is not currently recommended, as there is no clear evidence of benefit. Prophylactic antibiotics have not been shown to reduce mortality, extrapancreatic infections, or the need for surgical intervention. A meta-analysis demonstrated no difference in the rates of infected necrosis, surgery, or mortality between the patients receiving antibiotics and those receiving a placebo for the treatment of severe AP. Some studies have shown a small benefit in cases of severe necrotizing pancreatitis. Therefore, antibiotic use should be restricted to patients in whom infection is strongly suspected. It is possible that injudicious use of antibiotics in world of necrosis may lead to the development of resistant organisms once infection does develop. There is Atlanta classification of pancreatic fluid collections. Acute pancreatic collection lasts 4 weeks, occurs with interstitial pancreatitis, no fully definable wall, adjacent to pancreas, homogeneous fluid density, normal facial planes. Acute necrosis collection, less than 4 weeks, occurs with necrotic pancreatitis, no fully definable wall, heterogeneous, intra or extrapancreatic. Pseudocyst, more than 4 weeks, occurs with interstitial pancreatitis, well-defined wall, adjacent to pancreas, homogeneous fluid density, no solid component. World of necrosis. More than 4 weeks occurs with necrotizing pancreatitis, well-defined wall, intra or extra pancreatic, heterogeneous. Nutrition. In cases of mild pancreatitis, internal nutrition should be recommended as soon as abdominal pain has subsided. In severe pancreatitis, patients should be kept meal by mouth until fully resuscitated, usually after 48 hours, at which point normal enteral diet, if tolerated, or enteral tube feeding should be recommenced. Two meta-analyses have demonstrated that internal nutrition compared with parenteral nutrition decreases sepsis, organ failure, the need for surgical intervention, and mortality. Post-pancreatic feeding is no longer recommended unless there is mechanical gastric outlet obstruction or the patient is unable to tolerate nasogastric tube feeding. Parenteral nutrition should be reserved for patients who are unable to reach nutritional goals with nasohumeral feeding. A delay of up to 5 days in the initiation of parenteral nutrition may be appropriate to allow for restarting of oral or enteral feeding. Pancreatic enzyme supplementation should be prescribed to patients with symptoms of pancreatic exocrine insufficiency. Alcohol-induced pancreatitis and gallstone pancreatitis. Patients with alcohol-induced pancreatitis may need alcohol withdrawal prophylaxis. Benzodiazepines, thiamine, folic acid, and multivitamins are generally used. Dedicated outpatient follow-up visits are advised to prevent recurrence. All patients presented with gallstone pancreatitis should be considered for cholecystectomy when they are well enough to undergo surgery. In cases of mild biliary pancreatitis, cholecystectomy should ideally be performed during the index admission or within 2 weeks of discharge, as interval cholecystectomy is associated with significant risk of readmission for recurrent biliary events. A systematic review found an 18% readmission rate for recurrent biliary events, a median of 6 weeks after index admission for mild gallstone pancreatitis. In cases of severe gallstone pancreatitis, cholecystectomy may need to be delayed until collections have improved, unless the patient is well enough for surgery and the gallbladder is some distance from the collection. In surgically unfit or frail elderly patients, ERCP with biliary sphincterectomy may be considered as definitive treatment. Also, the risk of sphincterectomy should be balanced against the risk of recurrent biliary events. Prognosis. Most patients with AP will improve within 1 week of conservative management and be well enough for discharge. The etiology should be identified and the plan to prevent recurrence should be initiated before hospital discharge. Long-term prognosis is based on the etiological factor and patient compliance to lifestyle modifications. AP generally resolves and leaves pancreatic function intact. Many patients progress to recurrent AP or chronic pancreatitis, and the risk is higher among smokers, alcoholics, and men. Guys, I need 2 minutes to check you, okay? Can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Students, thank you for your attention. Maybe any
Thank you, sir.
Thank you, sir.
questions for me?
Thank you, sir.
No, sir.
No, sir.
Thank
sir.
you, sir.
Thank you, sir. Goodbye.
До свидания, sir.
Bye.
Всего хорошего.
До свидания.